We can start now.
Yes, sir. Good morning, sir. Today I'm going to
Good
have
morning.
this on my video.
Yeah, go on.
Yes, sir. 26-year-old female patient from Rajasthan with occupation of housewife came to hospital with chief complaints of 2 episodes of hematemesis at the age of 11 years. She also has complaints of awareness of the left upper abdominal lump since 3 years and easy fatigability since 3 years. The patient was apparently asymptomatic till 10 years of age when she developed 2 episodes of hematemesis, which are 6 months apart. They were painless and small quantity of bright red blood. They were spontaneous and not preceded by nausea or retching. There is no history of blood transfusions, no history of hospital admissions during the episodes, and there is history of melena after the resolution of episodes. The hematemesis was not associated with postural dizziness or syncope, abdominal distension, altered sleep pattern, jaundice, or shortness of breath. Then later, she noticed a lump in the left upper abdomen since 3 years, which is insidious in onset and gradually increasing in size. It is associated with dull aching pain. There is no history of change in nature of the pain. There is no migration radiation or significant aggravating or relieving factors for the pain. The lump is associated with the early satiety. There is also history of easy fatigability since 3 years, but she is able to carry out her daily life activities and she doesn't engage much in the physical work. There is history of recurrent episodes of low-grade fever, but there is no history of bleeding gums, epistaxis, easy bruisability on trivial trauma, or menorrhagia. No history of food performance in the school, no history of growth retardation and delayed milestones. There is no history of heartburn, dyspepsia, chronic drug abuse, severe pain abdomen radiating to the back. There is no previous history of abdominal surgery or any other major surgery. Past history, not a known case of hypertension, diabetes, TB, asthma, coronary artery disease, and there is no history of recurrent episodes of jaundice or viral hepatitis. Perinatal history, she had normal vaginal delivery in the hospital. There is no history of delayed separation of cord or umbilical vein catheterization. Menstrual history, she attained menarche at the age of 13 years. Irregular cycles were present since 3 years. And then there's history of spontaneous abortion 1.5 months back. Treatment history, with the above complaints, she was evaluated outside and she underwent endoscopic banding thrice in the last 2 years. Personal history, she consumes vegetarian diet, her sleep is adequate and bowel and bladder habits are regular and there are no addictions. Summary, 26-year-old female with 2 episodes of hematemesis at the age of 11 years underwent endoscopic banding thrice in the last 2 years without any features of decompensation, with symptomatic splenomegaly since 3 years, with symptoms suggestive of hypersplenism, with no features of portal biliopathy or growth retardation.
Okay, start at the first slide. Yeah.
Yes.
Now, when you say from Rajasthan, which part of Rajasthan? Is it physically remote? Is she accessible to medical facilities?
Alwar, sir.
Does that have good medical facilities? I don't know Rajasthan.
Yes, sir.
So she has access to good medical facilities.
Yes, sir. It is not remote area, sir.
Yeah. What is the importance of this?
Sir,
Given
remote
the history.
is one of the indication where we perform elective surgery, like prophylactic surgery, sir. It is one of the
Prophylactic surgery like?
shunt surgery, sir.
Okay. You said 2 episodes of hematemesis at the age of 11 years.
Yes, sir.
What was the separation in the 2 episodes of hematemesis? And in between the 2 episodes of hematemesis, did she have eradication of varices?
No, sir. First, when at the age of 11 years, she had small quantity of hematemesis, sir. But she doesn't have any hospital admission or ICU admission, no blood transfusion, sir. She did have the history of melena after the hematemesis episode.
Okay, go on. Second episode?
After 6 months, sir.
Yeah, at that time, did she have medical admission?
She has just taken normal medication like from the nearby hospital, but she didn't have any hospital admission.
Okay. So what prompted the banding? Why did she go for banding?
Yes, sir. So actually, 3 months back, she was having 3 years back when she was having irregular cycles. She underwent checkup where she came to know about this splenomegaly, and later she underwent endoscopy, sir. So they saw large esophageal varices, and they did
Yeah.
band.
This you should mention. It's very, very important.
I
Because
mentioned.
did she have secondary prophylaxis? Is it failure of endoscopy? That is not clear from your history. It has to be very clear.
Okay, sir. Okay, sir. So she underwent primary prophylaxis, sir. Actually.
Where she underwent primary prophylaxis, she has had 2 episodes of bleed already. It is secondary prophylaxis.
Oh, yes, sir. Yes, sir.
Primary prophylaxis is varicose eradication before bleed.
Yes, sir.
Is
Okay.
it indicated?
Yes, sir, it is indicated, sir, because the high risk varices like large grade 2 and grade 3 varices need banding because they'll bleed at the later stage.
Yeah. What are all the methods of primary prophylaxis of varices?
Primary prophylaxis, where we get non selective beta blockers, and then we have endoscopic band ligation, and in few cases, like high risk cases, growth
What are all
retardation,
the drugs that can be used?
we'll use propranolol, non selective beta blockers like propranolol.
Is it effective in EHPVO?
Uh, it is few studies have stated that it is effective only in cirrhotic portal hypertension, but then clinically it is used in non-cirrhotic like EHPVO also, sir.
That's what I'm asking. Who has said it can be used in non EHPVO?
In EHPVO, like it is used clinically, sir. It
No, who has said it? Somebody's important paper has said uh, even in EHPVO and NCPF, beta blockers are effective, more so in NCPF rather than EHPVO.
uh,
Dr. Sareen.
Dr. Sarin.
Dr. Sareen has published a paper where he has shown that beta blockers are equally effective in EHPVO and NCPF.
Yes, sir. Okay,
What,
sir.
Anand?
Yes, sir. In the literature, as I know, sir, beta blockers are useful for the NCPF and CL, chronic liver disease. In the
Yeah.
EHPO, very less or little scarce evidence regarding
Yeah,
the beta blocker in
only
EHPO.
Dr. Sareen advocates it and he says it is beneficial.
Okay, sir.
Yeah. Okay. So, what are the other drugs used in primary prophylaxis? Have you read Baveno 7?
Uh, no, sir. It actually uses propranolol, tindolol, and then uh,
What about nitrates?
nitrates can also be used, sir. Sublingual
Which nitrate?
isosorbate nitrates, sir.
Isosorbide?
Nitrate.
Mononitrate. ISMN.
Yes, sir.
Isosorbide mononitrate is used. Okay. So, is it a short acting or a long acting nitrate?
It is long-acting nitrate, sir.
Yeah. Okay, go on. So, she noticed a lump in the left upper abdomen. What are
Yes,
the
sir.
possibilities for lump in EHPVO?
Sir, EHP spleen, one can be enlarged spleen, sir.
Hmm.
And other can be also because of spleen, the patient can have gastric outlet obstruction. And
Why gastric outlet obstruction?
no, if there is enlarged spleen, compressing stomach, or because of the
Enlarged spleen will not cause gastric outlet obstruction. It's on the left side. It
uh,
causes early satiety.
and
Our left lobe of the liver also can be enlarged compared to the right lobe. Right lobe becomes atrophic, while the left lobe becomes hypertrophic. Because the portal venous radicals they empty into the left portal vein, and the right portal vein is blocked. And because they are emptying into the left portal vein, preferentially the left lobe of the liver is maintained. And because the right lobe has atrophied, the left lobe can hypertrophy. So
yes,
often in EHPVO, you have an enlarged left lobe.
yes, sir. Yes, sir.
Yeah. Okay. What are all the causes for pain in splenomegaly?
The pain in splenomegaly, first, it can be because of its size, because it is massive in size, there can be uh, discomfort to the patient. And then there can be because of the, in fact, the patient can have acute pain. And hmm, any perisplenitis also will cause pain to the patient.
Okay. Okay, go on.
One important cause of pain in mesospleenomegaly is infarction of the spleen.
She
Yes.
said that.
Okay.
And then there's history of easy fatigability, sir, since 3 years. And then recurrent episodes of low-grade fever. And there is no history of bleeding gums, epistaxis, or irreversibility.
What are the importance of this symptom?
So basically, these symptoms we are asking to see whether she has features suggestive of hypersplenism or not. Anemia, leukopenia, and thrombocytopenia.
Which one causes these symptoms?
Easy fatigability is because of the anemia, sir. Fatigue.
You have mentioned no history of bleeding gums, epistaxis, easy bruisability on trivial trauma or menorrhagia.
This is because of thrombocytopenia, sir.
Okay.
Yeah.
Is thrombocytopenia in EHPVO symptomatic?
No, sir, it is asymptomatic, sir, in most of the cases, sir.
Why?
Because will
Spleen acts as a reservoir of platelets. That's why platelet count reduces. But platelet function is not abnormal. So there is no thrombasthenia.
yes,
So
sir.
if platelet function is abnormal, you should suspect a hematological disease. What are all the hematological diseases that you can suspect in this lady?
Hematological.
The previous episodes of hematemesis could have been peptic ulcer disease, or they could have been Mallory Weiss tear. What are all the possibilities in this lady?
Yes, sir. But then in those peptic ulcer or Mallory Weiss tail, the patient will have pain abdomen, which is not there over here. This is painless symptomasis, sir.
Okay, accepted. If pain had been there and then she had come with all these symptoms, what possibilities would you consider? What tests would you ask for to consider those possibilities?
For this, we generally have to do thromboprophylaxis, thromboembolism investigations, sir, like factor 5, factor protein C, protein S.
Yeah, you think that is likely here?
There's less chances, sir, according to her history.
Why?
Because she doesn't have any thromboembolic episodes, according to her history. So that
See,
is,
she has. Finally, when you tell the investigation, you will show thrombosis. You are saying it's EHPVO. So
okay, sir.
EHPVO is a thrombotic disease. Cannot EHPVO be a manifestation of protein C, protein S, antithrombin 3, and factor 5 Leiden deficiency?
Yes, sir, it can be, sir. It is one of the
Yeah. And is there any history of umbilical sepsis in this patient?
No, sir.
No. So it's more likely.
Yes, sir. Okay, sir.
Yeah. So you have to investigate for those things. What is the importance of investigating recurrently and frequently for those tests? One test might not prove abnormality. Why does it require multiple tests?
So that if the tests come out to be positive, sir, we can give treatment on those lines, sir. We can give prophylaxis on those etiological factor.
Okay, I'll tell you one scenario. She has come to you with her first bleed.
Yes, sir.
You do an ultrasound. There is EHPVO.
Okay, sir.
Will you do protein C, protein S, antithrombin 3, and factor 5 Leiden?
No, sir.
Why?
Sir, because the indications for doing these tests are basically when the patient has recurrent episodes of thromboembolic.
So you want the patient to suffer multiple diseases before you do the test?
Sir, actually, the age also matters, sir. If she has like engage, if she doesn't have thromboembolic episodes, or there is
She
family.
has thrombosis. I told you that on ultrasound she has EHPVO. That
No,
is
I
a
mean,
thrombotic disease. Portal vein thrombosis is there. She has come with hematemesis. Will you do protein C, protein S, antithrombin 3 at the time of bleed?
yes, sir, we'll do so.
You should
Like,
not do at the time of active bleeding because they will be abnormal.
yes, sir, after 4 to 6 weeks, we have to do, sir, after the
Yeah,
episode.
after 4. Why didn't you say that?
Yes, sir.
See, this is how you get caught in the examination. They will catch you at these points. When are you going to do the investigation? How are you going to do the investigation? You should know. Because if you do at the time of acute bleed, it will be positive
Hmm.
and it's of no use.
Yes, sir. So after
Yeah. At the time of acute thrombosis, you should not do.
false
You should
positive.
do after an interval of 4 to 6 weeks.
Yes, sir.
And you have to do it multiple times. At least you have to do it 3 times at 3 months interval before you can catch it because it is episodic. It is not constant. Protein C, protein S, antithrombin 3, and factor 5 Factor 5 Leiden is constant, but protein C, protein S, antithrombin 3 is episodic. Therefore, it may not be positive at all times.
Okay, sir.
Okay, go on.
No history of poor performance in the school, no history of growth retardation and delayed milestones, sir. And there's
What
no
do you
history.
know about this? Can you quote a paper and tell us some information about growth retardation and delayed milestones?
Uh, usually in patients with EHPVO, sir, because of the deficiency of the growth factor on insulin-like growth factor reduced, and there is mucosal changes, there will be growth retardation, mucosal changes because of the portal pressure, increased portal pressure, there will be growth retardation.
Okay. Who has reported it? How much is the growth retardation? What is the proof that growth retardation is because of EHPVO?
Mm. The the paper I'm not aware of, sir.
What is the proof?
Uh,
I say growth retardation is because of nutrition,
yes,
not
sir.
because
So
of bleed,
following
not because of portal vein thrombosis.
following splenectomy, the growth there, if we see there's a growth spurt
Following splenectomy or following something else?
following shunt surgery, sir.
Yeah, following shunt surgery, there is correction of growth retardation and the patient rapidly returns to the normogram.
Yes,
That
sir.
is the proof. And again, this is a paper by Dr. Sarin. It is not accepted by the AIMS group that it causes significant growth retardation, though there is a paper by Somiran Nandi on this paper, on this issue.
Yes, sir.
Okay, go on.
uh, Perinatal history, normal vaginal delivery at hospital, and then there's no history of delayed separation of cord or umbilical vein catheterization.
Okay.
And then mentioned
Where would umbilical vein catheterization be done?
in hospital.
For what?
Usually when the patient have uh, negative discriminatory of the blood group, negative pregnancies for
What? You do it for exchange transfusion in erythroblastosis fetalis.
asthmapheresis, sir. Yes, sir. Where
Yeah.
the yes, sir.
And you can do it for transfusing blood in an anemic child, such as in a twin pregnancy where there is plethora in one child and there is anemia in the other child because of a common placenta. You can transfuse blood through the umbilical vein after the child is born.
Yes, sir.
Okay. What are all the other reasons for doing in utero umbilical transfusions?
Uh, it is usually done when there is the same reason. So one is the one child is having anemia, or when the development of one child is less and one child is more.
It is done for erythroblastosis fetalis, or if there is Rh negative pregnancy and there has been previous pregnancy loss, if you want to prevent it, you will transfuse this child with O negative blood.
Yes, sir.
Okay, go on.
Menstrual history. She attained menarche at 13 years. Their irregular cycle since 3 years. And then
What
there's,
is the reason for irregular cycles?
it can be because of anemia, sir.
Okay, what else? It
Uh,
causes anemia or it is because of anemia?
because both a cause and effect relation. Irregular cycles
Okay.
because of anemia,
What else?
and other thing can be oligomenorrhea.
Okay, go on. Why
And
did she have spontaneous abortion?
actually, this states towards the prothrombotic state, like antiphospholipid antibody syndrome.
Exactly. So, is it possible?
It can be one of the causes. So upon investigating, we will see.
The important history is recurrent abortions occurring in the first trimester can be because of antiphospholipid syndrome.
Yes, sir.
Okay, next.
The treatment history I stated, like 3 years ago, she got evaluated, and then she underwent banding in the last 2 years, sir, 3 times, sir.
Okay.
And then personal history, and then summary. 26-year-old female with 2 episodes of hematemesis at the age of 11 years underwent endoscopic banding thrice in the last 2 years without any features of decompensation, with symptomatic splenomegaly since 3 years, with symptoms suggestive of hypersplenism, with no features of portal biliopathy or growth retardation.
Okay. Let's go on. Let us proceed.
Yes, sir. Examination. She's conscious, oriented.
Why did you think of NCPF in this lady? Is NCPF a possibility?
Sir, actually,
What is the age group at which NCPF presents and at which NCPF affects?
it is usually third decade, sir, but
Yeah.
because this there's no etiological exact history of for EHPVO, and there is no.
What are the other features that support NCPF diagnosis in the symptomatology?
Yes, sir, there's no etiological history of EHPVO, and then there's no biliopathy features, and there is
I'm
splenomegaly.
not talking about EHPV. I'm talking about NCPF.
Yes, sir. NCPF splenomegaly is there, sir, and then bleeder is there, well tolerated bleeder.
Do they tolerate well NCPF?
Uh, Compared with the EHPO, less well
I'm
tolerated.
not saying NCPH. I'm saying NCPF.
NCPF, sir,
Yeah, compared to EHPV,
less well tolerated, sir, but it is tolerated, sir.
what happens?
There'll be
What
20.
happens to an NCPF who bleeds?
Yes, sir. Following the bleed, there'll be 25% chance of decompensation present.
Okay, what is the form of decompensation?
Jaundice or ascites, sir, mainly,
Yeah,
and then jaundice, sir.
jaundice. What about encephalopathy?
Mild, no encephalopathy,
Encephalopathy also,
no.
because there are large shunts in the retroperitoneum which are shunting the blood. Whenever there is a bleed, they develop encephalopathy. And the
Okay.
splenic vein is usually very large. So the flow is very high. That's why they develop encephalopathy. Okay. Is this features there?
No, sir, she doesn't have.
So why did you consider?
Uh, Less likely, sir. Just on the DD lines down the
You
line.
can't include it without support in your history or findings. Spleens are very large. All this history will be there. Then you can suspect NCPO. What are the other causes of GI bleed? You have not included those as a differential diagnosis.
Uh, Here I mentioned about other causes. Here I mentioned that it is not preceded by nausea, retching, sir, which suggests, and it is painless. So, which is ruling out peptic ulcer disease and then Mallory
Is
Weiss.
peptic ulcer always painful?
Uh, yes, sir. Most of the times, peptic ulcer bleed is painful.
Is it? Doesn't bleeding cause neutralization of the acid and the pain disappears?
Can be, sir.
Yeah. So peptic ulcer disease is a possibility. What else?
It can be Mallory Weiss stayed.
No, not Mallory tear here. Where is the history of vomiting? No recurrent vomiting. She doesn't have retching. What
Yes,
is
sir.
Mallory tear?
When the patient will have recurrent episodes of retching followed by the hematemesis,
Yeah.
which is
What happens with the retching?
because of the increase in the pressure, increase in the intraluminal pressure, there will be mucosal bleed.
Mucosal bleed.
I mean, mucosal taste,
Mucosal tear. Where?
GE junction.
Yeah, at the G junction. Is that a possibility? That is not there. That history is not there. So you cannot entertain that possibility. What other possibilities?
Uh, it can be like since we haven't examined yet, so we can think of gist also, sir, because there's a lump and then there's painless bleeding,
Yeah. Just what else?
and then any vascular abnormalities like gave dilufoil
No.
lesion.
Okay. So portal hypertensive gastropathy.
Yes, sir. What happened?
What else?
And um,
AVMs.
how
AVMs of the stomach.
yes, the vascular malformations.
Yeah. Okay. So these you should keep. If you don't keep this, then there is no differential diagnosis. Why? On what basis? Just because there is splenomegaly and there is bleed, you can lump and there is a bleed. You cannot think of portal hypertension only. You have to keep a differential diagnosis, and this is the differential diagnosis that you must keep. And you have arguments for and against each of them.
Yes, sir.
Okay, go on. Go on with the differential diagnosis. Go on beyond that.
Examination. She's conscious, oriented to time, place, and person. She's lying comfortably on the bed. Her pulse is 72 beats per minute and BP is 110/70 mmHg. Her saturation is 98% on room air and afebrile. Hydration is adequate. There is pallor but no icterus, clubbing, cyanosis, generalized lymphadenopathy. No signs of stigmata suggestive of chronic liver disease and no petechiae. Oral cavity examination is normal, no gum bleeding. Her height is 152 centimeters, weight is 54, and BMI is 23.3. Coming to the examination of the abdomen, on inspection, abdomen is flat, umbilicus is central and inverted. All quadrants are moving with respiration. Visible fullness is seen in the left hypochondrium, which is extending to left lumbar and umbilical area and is moving with the respiration. No dilated veins, scars, sinuses seen. On palpation, the abdomen is soft and non-tender. Spleen is enlarged and it is palpable 10 centimeters below the costal margin, extending up to the umbilicus with palpable anterior notch, smooth surface, well-defined margins, and it is firm in consistency. Liver is not palpable below the costal margin and no other palpable lump is present. On percussion, the liver span is 13 centimeters and there is no evidence of free fluid. On auscultation, normal bowel sounds were heard and there is no bruit or venous hum heard. The genitalia examination is normal. Distal rectal examination is normal and no black color stools was found. Other systemic examination is also normal. To summarize, 26-year-old female with 2 episodes of hematemesis at the age of 11 years, post endoscopic banding thrice in last 2 years without any features of decompensation, with symptomatic splenomegaly since 3 years, with symptoms suggestive of hypersplenism, with no features of portal biliopathy or growth retardation. On examination, it reveals pallor with massive splenomegaly without any stigmata of the chronic liver disease.
What is massive splenomegaly?
Massive splenomegaly generally we will tell the regarding the size.
Yeah,
From the
tell.
less than 3 centimeters, 3 to 5 centimeters, and greater than 7 centimeters.
You also say if it crosses the midline, then you say massive.
Yes, sir.
If it doesn't cross the midline, you won't say massive, it's moderate. If
Okay.
it reaches the midline.
Okay, sir. Hmm.
Okay, go on.
Yes, sir. And then I would like to further proceed with the management.
Okay. What about other systems?
Other systemic examination is normal, sir.
What neurological tests did you do in this patient?
Um, we'll see for the any motor examination, tremors, and uh, sensory
What
examination,
type of tremors?
clapping tremors,
What else?
and
Can there be fine tremors?
fine tremors is seen in neurological disorders, sir, like any
Can
cerebellar.
this be Wilson's disease?
This can this be Wilson?
Wilson's disease. You have not mentioned cases pleasure ring is absent.
Okay,
You
sir.
didn't examine the eyes. You didn't look for case pleasure ring.
Yes, sir. Okay, sir. It's not, I didn't
That's a
mention
mistake.
it's not there, sir, and it cannot. Yes, sir.
Yeah. What test did you do for subclinical encephalopathy?
Uh, the the memory of the patient
That is not affected by subclinical encephalopathy.
calculations, sir.
Reverse counting,
Mathematical calculations, sir.
figure drawing, reverse counting, figure drawing,
Yes, sir. Mathematical calculations also.
mathematical calculations, joining different numbers in sequence
Hmm.
written on a paper. All these tests you should do. If you don't do these tests, how can you rule out subclinical encephalopathy? NCPF has subclinical encephalopathy. EHPVO doesn't usually have encephalopathy. You yourself have included a differential diagnosis of NCPF, but you have not paid any attention to the neurological system. She is a young girl with portal hypertension. You haven't ruled out infiltrative diseases. You haven't ruled out metabolic diseases of cirrhosis.
She doesn't have any history of metabolic disorders, sir.
What history will be there? Only splenomegaly will be there, hepatomegaly will be there. In lipid storage disorders, in glycogen storage disorders, there will be just hypoglycemia and there will be hepatosplenomegaly. She's a bit old for that. If she had been 13-year-old, you could have considered that.
Hmm.
But she's a bit old for infiltrative diseases.
Yes, sir.
But portal hypertension can be seen in these conditions.
Yes, sir. If they are the,
What is nodular regenerative hyperplasia?
it is one of the cause of compensated cirrhosis, sir.
Yeah. So nodular regenerative hyperplasia is usually seen in women. It's usually seen in the age group of 20 to 30. It presents like NCPF and the liver is hard and irregular like cirrhosis. You did not mention anything about the liver consistency, border, or whether it's palpable or not. You did not mention anything. You only mentioned liver span is this much.
Liver is not palpable below costal margin, I mentioned.
Okay.
And
Okay. Go on.
yes, sir. Now
Proceed.
now I would like to further proceed with the management of the patient, sir.
Okay.
Yeah. First, we'll review the old endoscopic reports which she has,
Okay.
and then followed by the blood investigations, sir.
Okay.
And then in blood investigations, we can see that the patient is having anemia with leukopenia and thrombocytopenia. And then the urea and creatinine are within the normal limits. And then the electrolytes of the patient are also normal. And then there's no raised alkaline phosphatase. There's no coagulopathy, and the synthetic function with of the liver, like with albumin, they are normal. and the viral markers are non-reactive.
Okay. What does this support? Now, at this moment, you have a mass in the left hypochondrium and you have this picture of pancytopenia.
So it generally suggests hypersplenism, sir.
Okay. So, what are the implications of hypersplenism? What happens with hypersplenism? When is hypersplenism an indication for surgery?
Hypersplenism, when the patient it is symptomatic, when there is symptomatic hypersplenism, like manifestation of anemia, leukopenia, and thrombocytopenia.
It's an indication for shunt.
Yes, sir.
Then why was it not done?
Shunt surgery, sir.
Yeah. They are doing banding.
Yes, sir. For those, it was referred over here, sir. For the
Where there is a massively enlarged spleen with hypersplenism, which is symptomatic, with severe symptoms of splenomegaly, that is a soft indication for a shunt.
Yes, sir. So before performing shunt surgery, we have to look for the anatomy of the vessels also, like
No, you tell about endoscopy first. You're not proven it is portal hypertension. Where is the anatomy of the vessels coming in?
endoscopy reports, sir, like which is done in our hospital. It is showing there are large esophageal varices with portal hypertensive gastropathy.
Okay. So large esophageal varices means what? Classify varices.
When there are three grades of varices are there, sir, where the grade one is short varices, short and straight, and then grade two is dilated tortuous, which is occupying less than 1/3 of the circumference, and grade three is dilated tortuous varices, which are occupying more than 1/3 of the circumference,
And
and
grade 4?
compressing.
No. Red veil markings.
Yes, okay,
What
sir.
are the red markings that you seen in varices?
Discrete red spots we see, sir, which are like stigmata of the recent bleed.
What are they? Tell me the names.
Cherry red spots
Cherry red spots.
and blood clot
No,
mosaic.
no. Red veil markings, cherry red spot, hemocystic spot, varices on varices. What are varices on varices?
When the varus bleeds,
What are varices on varices? There will be another small varix on top of a large varix. That is called as varix on varix. Red veil markings is like a smear of red paint on the varix. Hemocystic spot and cherry red spot are different sizes of red spots. They indicate submucosal bleed of the varix.
okay, sir.
These are the precursors of varicose bleed. Suppose these are there. What is your strategy?
We have to proceed with the ligation, varicose ligation of the patient because these indicate that it might bleed,
Okay.
high chance for bleeding.
Okay. What about medication?
We'll give non-selective beta blockers to the patient, sir.
Okay. How much dose?
3.12.
How do you titrate the dose of beta blocker in a patient with portal hypertension?
Usually we give first oral medication twice daily, and
Is
then
it twice daily, once daily? Is that based on just the frequency or you base it on something? Are there any hemodynamic parameters you look for?
yes, sir, her heart rate.
Yeah, how much should it be? How much should it drop?
Uh, Approximately 10%.
Yeah, it should reduce 10 to 20% from the normal heart rate. And blood pressure should drop 10 to 20 millimeters of mercury. That is
Yes,
an indication that you have adequately beta blocked the patient.
yes, sir.
Okay. What about, will you combine it with isosorbide mononitrate?
Usually it is not required, sir, but when it is
Usually it is combined and it is at a dose of 5 milligrams. It's a long acting nitrate, so you give it only once a day or at the most twice a day. And you combine it with beta blocker, that reduces the bleed by 30%. Okay, go on. What is your portal hypertensive gastropathy? What is the grading of portal hypertensive gastropathy in this case?
portal here the gastroesophageal varices of the type 1 are present, sir. That is, the varices are present on the lesser curvature of the stomach.
Okay. What is GOV2?
When they are present on the fundus, sir.
Esophagus and fundus.
Esophagus and fundus.
IgB1.
IgV1 is where they are fundic varices, and IgV2 is when they are uh, uh, on the elsewhere in the stomach.
Antral or usually body of the stomach, not in the fundus. How do you look for the gastric varices?
In endoscopy,
In
uh,
endoscopy.
it's like first we'll inflate, and then using the J maneuver where we'll come down, and then again we'll
What is that maneuver called? Retroflexion of the scope.
see retroflexion.
Retroflexion of the scope. You'll see the fundus and you'll see the lesser curve.
Yes, sir.
What is the difference between gastric varices in the fundus and gastric varices along the esophagogastric junction and the lesser curve? What is the difference between GOV1 and IgV and GOV2?
They
What
vary.
is the importance of this classification?
Uh, they vary according to the chance of bleeding, sir.
No.
Bec-
If you eradicate esophageal varices, GOV1 gets eradicated completely, including the gastric varix. But in GOV2 and IgV, eradication of esophageal varices does not eradicate the gastric varix. And gastric varix can independently bleed, and bleed chances increases once you eradicate esophageal varices.
Okay.
Okay? Yeah. Okay, so what is the grades of portal hypertensive gastropathy?
Uh, Grades or again three
You know
grades.
or you don't know?
No, sir, I don't know.
You refer then.
Yes, sir.
What is gastric antral vascular ectasia? What is the other name for it?
Watermelon stomach.
Okay, watermelon stomach.
Yes, sir.
How do you diagnose gastropathy on endoscopy? How does it look? Mucosa, how does it look?
The mosaic-like pattern will be seen.
Mosaic-like pattern. Okay. Next, go to the next investigation.
Next investigation, as depending on the blood investigations, as we have seen the hypersplenism picture. So we'll get one corrector retic count and also peripheral smear of the patient,
Okay.
and then followed by ultrasound with the
Is
Doppler.
this an abnormal corrected reticular count or is it normal?
It is normal, sir. This retic count
Normal is less than 1%.
up to corrected is up to 2.5% is normal.
Okay.
And then peripheral smear, which is showing pancytopenia.
Why does this patient have microcytic hypochromic anemia? She has bled many, many years ago and she has been banded. She has not bled again. So why does she have microcytic hypochromic anemia?
One can be because of nutritional, where she is having early satiety. So iron deficiency can be common, sir.
What else?
Uh,
Based on endoscopic findings.
Clinical bleed can be there, sir, with melena.
Because of, not melena, but because of continuous bleed loss from portal hypertensive gastropathy.
Yes, sir.
Portal hypertensive gastropathy is also a cause for bleed. And that results in, just give me a second.
Yes, sir.
Yeah.
Yes.
So portal hypertensive gastropathy can have subclinical bleed, and that can result in microcytic hypochromic anemia. And recurrent microcytic hypochromic anemia, despite treatment of and checking of iron stores will keep falling. And you have to check the iron stores, and you have to shunt the
Long.
patient because portal hypertensive gastropathy has to be
बेलुका जाने
relieved.
जानुपर्ने होइन हुन्छ मैले 15 मिनट क्लास सिधाइहाल्छु कि
Mr. Uttam, please silence yourself. So portal hypertensive gastropathy, which is bleeding, can also result in hypoproteinemia, edema. There can be enteric loss of albumin, and that can result in hypoproteinemia and nutritional deficiencies. That also is an indication for shunt.
Yes, sir.
Yeah. Why do you think this patient doesn't have portal hypertensive biliopathy?
Actually, there is no history of jaundice, sir.
She doesn't have symptomatic biliopathy, but she could have silent biliopathy.
Yes, sir, that can be there because of the
What
long.
are the biliopathy changes that are seen in portal hypertensive biliopathy?
Usually, there can be dilatation, stricture, angulations, stones.
What is
And
the cause for a fixed stricture after shunt?
it can be because of the ischemia of the bile duct, sir.
How?
The long standing, when there is long standing collaterals around the CBD, compressing the CBD, there can be ischemia of the bile duct resulting in the stricture, which is not corrected after the shunt surgery.
Yeah. Was this more common in the days of sclerotherapy? Some people used to say the epicholedochal veins were getting thrombosed because of leakage of sclerosant into these epicholedochal veins, and that was causing the stricture. How do you manage that?
By preventing the leak of
No,
the
how do you manage stricture, fixed stricture after shunt?
after shunt, we'll usually wait, sir, and then followed by we'll do the
Alkaline phosphatase is raised, bilirubin is raised, there is a fixed stricture on ERCP. How will you manage?
bilioenteric anastomosis, sir.
No, you can do dilatation and stenting.
Okay.
Why do you want to do surgery? Is surgery simple?
No, sir. The access
You
is
can do dilatation and stenting. If that fails, then you submit the patient for surgery. Okay. Let's go on.
yes, sir. And
How
then
will you like to investigate further?
and
What
then
do you want to do first?
ultrasound with color Doppler of the patient, sir.
What do you want to do?
Ultrasound, sir.
No. Do you want to do a procedure or you want to just send the patient for banding?
No, first we'll band, sir, and then followed by further investigate further surgery, sir.
Why surgery?
Sir, because firstly, the in
She has
EHPVO,
had 2 bleeds nearly 15 years ago. She has been successfully managed with endoscopic banding. She doesn't have any, she has only anemia, which you have not investigated. You didn't mention any iron studies.
So, sir, basically, after banding, the chance of the bleeding from the gastric varices will be more.
There are no gastric varices here. They are there only in the GOV1. GOV1 will be eradicated with eradication of esophageal varices. What do you want to do?
And there is also hypersplenism of the patient, which is symptomatic.
Like I said, hypersplenism, she doesn't have easy bruisability. She doesn't have easy infection. She has only anemia.
She
And
also
anemia can be because of portal hypertensive gastropathy, which may or may not be relieved by shunt. What is the pathogenesis of portal hypertensive gastropathy?
she also has history of fever also, sir.
You didn't give that history. You said no history of fever.
No, sir, I mentioned the history of fever is there, sir.
No. Okay, low grade fever. What can the cause for low grade fever be? Sepsis?
No, sir, like minor respiratory tract infections or any.
Yeah, so that is not because of hypersplenism. And if you remove the spleen, you will expose the patient to OPSs. Infections will not reduce by splenectomy.
Yes, sir.
So
Leukopenia.
why do you want to remove the spleen? No history of infarcts, no history of severe pain, just a dull aching pain, no history of significant early satiety. Her BMI is normal. 23.3 is the normal BMI. Nutritionally, she is not being affected. She has no growth retardation. She has had normal development of milestones. She could have just iron deficiency anemia. You correct the iron deficiency anemia and she'll be fine. And you continue your management with the banding.
He also has thrombocytopenia, sir. On investigation.
Thrombocytopenia, like we said, is not symptomatic in hypersplenism. That is not an indication for splenectomy.
Oh, generally we'll do surgery, splenectomy also in cases where there is
See, Harita, in this patient, there are no strong indications for shunt surgery except that she has come to the surgery department. There are no strong indications.
yes, sir.
You can manage this patient conservatively with the banding for some more time. But spleen is moderately enlarged, therefore, and there is dull aching pain. Patient is worried. There is a chance of rupture of the spleen. Therefore, you can say, I want to do a splenectomy and a shunt. What is the chance of rupture of the spleen in patients with splenomegaly?
25%.
It is very low in portal hypertension because the capsule is thickened. On the contrary, in malarial spleen, the spleen is very friable. In malarial spleen, if you have a moderate to massive splenomegaly, then in chronic malaria, it's an indication for splenectomy. In patients with only splenomegaly in portal hypertension, the spleen is very secure. But accidental trauma can result in rupture of the spleen.
Okay, sir.
Okay? Yeah. Okay. So you want to do a shunt. So how will you investigate?
Yes, sir. First, we'll proceed with the ultrasound of the abdomen with color Doppler.
What does it show? I can't read it.
Yes, sir. The liver is normal in size, 15 centimeters, and shape with smooth margins. Ecotexture of the liver is normal. No focal space occupying lesion is seen within the liver parenchyma. And then IHBRD is not present. And hepatic veins and portal venous radicals are normal. Portal vein, multiple tortuous vascular channels replacing the portal vein is seen, which is suggestive of portal cavernoma. and then visualized part of pancreas appear normal.
You said portal vein is normal.
Portal vein is replaced with portal cavernoma, sir. Visualized part of
But
pancreas is normal.
what about intrahepatic portal vein?
It is not mentioned over here, sir.
Is it required?
No, sir. Regardless of the intrahepatic portal vein or splenic or superior mesenteric vein involvement, only the extrahepatic portal vein thrombus is considered as the EHPVO.
What is rect shunt?
Rect shunt is where we'll do the mesenteric, superior mesenteric vein with the left portal vein, sir.
So isn't it important?
Yes, sir.
Why is the rect shunt superior to proximal splenorenal shunt?
Sir, rect shunt is basically a bypass procedure where directly we'll do, keep in internal graft between the left portal vein and the mesenteric, superior mesenteric vein.
Yeah, so what is the advantage?
Is
What
direct.
is the importance of hepatopetal flow in liver physiology?
So it basically improves the left lobe of the liver supply, and there is increase in the size of the left lobe.
Yeah.
So post transplantation, it will be helpful for the patient.
Post transplantation.
Post liver yes, sir. When there is the portal vein thrombus, we can do this shunt so that there will be increase in the liver size, left lobe of the liver size.
So why do you want to do transplant?
No, I'm telling in cases of transplants. Sir.
So you'll do rect shunt only in transplant?
No, sir. No.
Then is it not the ideal treatment today in the West for EHPVO?
Yes, sir, it is, sir.
Because it maintains hepatopetal flow and PSRS is hepatofugal flow. Therefore, the liver becomes small and atrophic.
Yes, sir.
So the hepatotrophic factors from the portal system do not reach the liver. They flow away from the liver. And hepatofugal flow also increases the chance of subclinical encephalopathy. What is the chances of subclinical encephalopathy in shunt?
There is
Read it up. There are papers on this.
yes, sir.
Please read Dr. Sarin's papers, Dr. Mathur's papers, Dr. Mathur's classification of varices,
Yes, sir.
Dr. Sarin's classification of varices. You told that, but you should know Dr. Mathur's also. He is a surgeon. He has done a lot of work. There are a lot of papers by both these people and by Dr. Someran Nandi, AIMS group. You should read all these papers. Then Dr. Richa Lal has also written papers on portal hypertension in children. You
Yes,
should
sir.
read these. You will be asked all this. Okay. I will say your performance was average. I am not happy with your performance.
Sorry.
You need to read.
Yes.
Anand, shall we finish?
Yes, sir. We can end up the session, sir.
Yeah,
Thank you.
because there's still a lot to discuss, but we'll discuss in another class.
Yes, sir.
Yeah. Thank you.
Thank you.